Good morning and welcome to this presentation on how research can inform implementation. I'll be focusing on the use of formative research and asking the right research questions. My name's Tom Davis and I'm Partnership Leader for Health and Nutrition for World Vision International. I'm a huge believer in using formative research at the beginning of programs as a way to improve outcomes and increase impact, since the best programs with which I've been involved started with a lot of rapid formative research and continued to use it during the program to tweak the implementation. Formative research is conducted during the development of a program to help decide on the target audience, describe the target audience, to understand the factors which influence their behavior, and determine the best way to reach them. Some examples of this are positive deviance studies, trials of improved practices, behavioral barrier analysis, human-centered design, retrospective mortality studies, ethnography, and focus group discussions. This is a publication on a project that I helped design a few years back where we used three different forms of rapid formative research: a positive deviance inquiry, a retrospective mortality study, and 4 barrier analysis studies. I'll talk about 2 of those methods. This is an important project to learn on, since the final evaluator of this project and one of the co-authors of this study remarked, "As far as we know, this is among the most cost-effective child survival projects ever implemented at scale." Perry has published extensively on the effectiveness of primary health care programs, so that means a lot coming from him. This project reached a population of 1.1 million people and achieved an overall 38% reduction in underweight in children under 5 within less than 5 years. We also saw excellent results in terms of adoption of health, nutrition, and wash behaviors, an estimated 36% decline in under 5 deaths. And we did all of this at a cost of only $2.78 per beneficiary per year. And that cost includes everything: all project costs, backstopping costs, training, indirect costs, everything. The cost per life saved was only $441, which was 5 times less than the average child survival project. So how did formative research inform this project? Well, first we conducted a rapid positive deviance study, which we called a local determinants of malnutrition study. And in this study, we interviewed about 45 caregivers of children 12 to 59 months of age with a good weight for age, excluding those caregivers with higher income, etc., and then compared them to about 45 caregivers of children 12 to 59 months of age who were underweight. We then looked for statistically significant differences among those two groups in terms of foods consumed, feeding practices, childcare practices, care-seeking practices, and some mindset questions. We also explored things like maternal depression and alcoholism in the family and corporal punishment. We found a lot of useful information from these PDIs in 4 countries. In Mozambique, among the 12 important findings, we found that 45% of mothers of the well-nourished PD children said that they usually or always completely emptied their breasts when breastfeeding their child, while only 10% of the mothers of malnourished children did this. For you non-nutritionists out there, this is a very important behavior, because the first milk to come out of the breast, the fore milk, typically has more water in it and less fat, which is great for hydration, but it's the hind milk, the last milk to come out, that is richest in terms of fat and thus calories. This finding led to our putting a lot more attention on that important behavior and developing key messages around it, and by final, 99% of mothers said that they were doing this. PDIs can be extremely useful for identifying overlooked but important behaviors that are associated with a good outcome, like a healthy weight for age. World Vision did a World Health Assembly side event here in Geneva a few weeks ago, and at that, a WHO representative working on the acute malnutrition guidance mentioned that doing these sorts of positive deviance studies on wasting would be very useful to the WHO. So let's get cracking on that research. This study also found about 10 other important findings, one of which was that PD children were 3.6 times more likely to be consuming treated drinking water than malnourished children. So we boosted our emphasis on WASH in the project. After the PDI, we conducted 4 barrier analysis studies, one of which was on exclusive breastfeeding, since only 17% of children 0 to 5 months were being exclusively breastfed at baseline, and we wanted to know why. Through those studies, we found why some moms exclusively breastfed and others do not. For example, mothers who exclusively breastfed were 4.5 times more likely to say the lower cost of exclusive breastfeeding was an advantage of it, and that their friends and family members approved of the practice. So we used the method to reach more influencers and messaged around the low cost. But rather than boring the ag folks with yet another breastfeeding example, let's look at how barrier analysis is applied to an agricultural problem. So barrier analysis is a major tool that we promote and that is promoted in USAID's guidance on integrating social behavior change into climate change adaptation. It's a rapid assessment, formative research tool to identify the behavioral determinants associated with a particular behavior. These studies are done to develop more effective behavior change messages and activities, and a key feature is that you interview those doing a behavior, the doers, and compare their responses to those who are not, the non-doers. And this comparison allows you to look for correlations between responses and the behavior so that you can better identify what may be driving behavioral adoption. Barrier analysis has now been used in more than 40% of lower and middle income countries, and analysis is done with a simple spreadsheet. Barrier analysis has been used extensively for nutrition, but also for health, agriculture, wash, and other types of behaviors. The determinants in the box at the bottom are the usual determinants that are explored in these studies, things like perceived social norms, whether you think that people important to you approve of the behavior, but also perceived severity, whether you think that the problem is serious or not. However, it's flexible, so you can look at other determinants. There are lots of barrier analysis studies in the published literature. There also have been over 150 other BA studies, mostly done in lower and middle income countries, on a lot of other behaviors, some of which appear in the published literature. And you can see from these examples that barrier analysis has been used to study behaviors as different as the use of dairy products, to youth playing with unexploded ordnance in Kurdistan, to hand washing with soap, to dietary salt reduction. I won't go through all of these steps in the process, but the main idea is to interview 45 or more doers and 45 or more non-doers of a practice or a behavior, and then compare the responses, looking for statistically significant differences. You then use the results to develop activities and messages to promote the behavior. Let's now look at an ag example from barrier analysis, a case history from Guatemala, where an INGO was promoting a natural resource management practice that is helpful in mitigating the impact of drought, something that we know is impacting on malnutrition globally. And the Catholic Relief Services Segamaya program, they were working in two different departments in Guatemala, San Marcos and Baja Verapaz. These two areas are very similar culturally and otherwise. And in June of 2009, the staff in San Marcos were trained on barrier analysis. The practice that they wanted people to adopt was planting live barriers along the edges of planting terraces. Live barriers are strips of vegetation planted along the contour of land which serve to anchor the soil in place with their roots and to slow down the movement of water downslope with their stems and leaves. This helps mitigate some effects of climate change. CRS had already been trying to get people to adopt this practice for years, yet very few people adopted the practice, despite the fact that it only required labor and local free plant material. They did the barrier analysis study in San Marcos, and they had planned to do it in the other department, but got too busy. And what that allowed them to do was to see if it made much of a difference to use barrier analysis and apply the findings. Baja Verapaz served as a comparison area to examine the results of using BA. There, they just determined their strategy and messaging using their past experiences in the areas, cross-sectional survey data, etc. Just business as usual. So in the San Marcos barrier analysis, they found that most farmers already fully understood the advantages of the practice, which is what they've been promoting, but that the doers of the behavior worked together to plant the live barriers. Doers liked the practice also because they did not lose plantings due to drought. People who tried the behavior but lost plants due to drought abandoned it and did not want to attempt it again. Given the findings, staff focused there on organizing farmers to work together on each other's land during the off-season to plant the live barriers, and also have farmers brainstorm ways to prevent loss of plants due to drought, then train them how to diminish that potential negative consequence of the behavior. So what difference did they see by doing this study and responding to the results versus the comparison area? In terms of adoption of the behavior, measured in terms of hectares planted with live barriers, adoption in San Marcos, where barrier analysis was used and applied, the blue line, increased by 4-fold in 1 year. Adoption in Baja Verapaz, where they did not apply barrier analysis, the red line, business as usual, decreased by 25% that year. Focus groups with staff also found that it really changed how they thought about behavior change, their role in it, and the usefulness of this sort of data. So these are two types of formative research can really add value for projects, PDIs and barrier analysis. Let's now talk about some research questions. One question I'm most interested in right now, and I think more people should be giving attention to, given this huge hunger crisis that is developing, is what program models and approaches can reliably prevent wasting, the most deadly form of undernutrition, at the lowest cost. And one way to do that would be to replicate the study shown below. This was a CRCT done in Burundi, which found that the care groups approach, coupled with food rations and a small dose of health system strengthening, can reduce wasting by 50% compared to controls, with the greatest impact being on the most vulnerable children. This study shown here was a CRCT by Tufts University and others on the Tubaramuri project in Burundi, one of the poorest countries in the world. The project also reduced stunting and anemia, increased household food security and diets, and improved motor and language development. I think we should be looking very carefully at multi-sectoral models like this, which are producing results across sectors. With World Vision's multi-sectoral version of the care group approach, which we call nurturing care groups, we found large improvements in clean water and reduced harsh discipline of children as well. This can be attractive to governments since they can accomplish a lot across nutrition, health, agriculture, and other sectors with this type of behavior change model and platform, and change out the content depending on their current epidemiological priorities and the type of funding that they received. In that World Health Assembly side event on treatment of acute wasting that I mentioned, we heard strong calls for research on integration of models and approaches from ministries of health, WHO, SUN, and other NGOs. In Africa now, according to the Global Nutrition Report, the average prevalence of wasting and stunting is 6% and 31%, which means that 94% and 69% of children are not wasted and not stunted. And it's not that you will go to one community and find 2% wasting and another one nearby with 15% wasting. The greatest difference is between households and between cultural groups. And that means it may be in part due to behaviors, but also exposures. We need to do more high-quality positive deviance inquiries focused on wasting and stunting, and also barrier analysis studies to better understand why some people adopt certain health, nutrition, and ag behaviors that are important and others don't. We need to make it easy as possible for people to adopt behaviors and practices that improve their and their children's nutrition. That in a given context part of these questions is important too. We need to supplement global research and meta-analysis with national level contextual research, which means many of you watching this need to start publishing. And publishing results of formative research is a great way to get started. We also need to be asking how we can be better engaging communities, community workers, and family members in addressing agriculture, nutrition, and health challenges. For example, only 1 in 3 children needing wasting treatment are treated, and wasting is the deadliest form of malnutrition, but policy and investment have not caught up. World Vision taught family members how to assess their child for wasting using a middle upper arm circumference or MUAC tape. The children identified with wasting via family MUAC, which we call it, were referred for treatment earlier before wasting was more severe and harder to treat, and consequently, they were 11 times less likely to be hospitalized than those referred by community health workers. Caregivers were able to do this screening at 1/3 the cost as well, only $1 per child, as compared to screening by community health workers. We need to do treatment of uncomplicated wasting at the community level through simplified protocols for community health workers. The WHO says they need more evidence on that, so that's a priority for us as well. Having evidence on the effectiveness of that could be truly transformational. We should also be exploring what is different in children who have both stunting and wasting. We may need specific strategies and approaches to address this combination, and we don't have as much surveillance on it as we really need. Thank you very much.